Good afternoon and welcome to our Improving Access to Quality Medical Care webinar series produced by the Southwest Telehealth Resource Center, Arizona Telemedicine Program, and our Arizona Department of Health Services. Today we're very excited to have a rock and roll star of a 8-time Grammy Award winner here on our program, Carol Yarbrough. But before we introduce her, I'd like to first read this beautiful land acknowledgement. We respectfully acknowledge that the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and indigenous communities through educational offerings, partnerships, and community services. Thank you. So welcome on behalf of our Southwest Telehealth Resource Center, our fellow HRSA grannies, together we make great things happen, and all other participants. The Arizona Department of Health Services, WELL, ATP, and SWTRC welcome you to this free webinar. The practice and delivery of healthcare is constantly changing, with an emphasis on improving quality, safety, efficiency, and access to care. And of course, telemedicine can help you achieve these goals.
Carol, I don't believe you're sharing your screen.
Oh, okay. Okay.
So who is sharing? This is great. I just keep ripping along here.
I am sharing.
Yay! Webinar tips and notes. When you join the webinar, your phone or computer microphone is muted, and this is so that we can all enjoy the program without hearing dogs and everything else happening.
Just my dogs. Just
not my dogs. Time is reserved at the end for Q&A, and use the chat to ask questions during the program, and we can answer them as we go along. And Carol's great at sticking around and following them up after the fact. Please fill out the post-webinar survey, and it is being recorded, so it'll be the gift that keeps giving. And here you can see the link to the recordings after the fact, so you can share that and refer back to it. So today's program is Medicare Physicians Fee Schedule 2023 Draft and the impact on rural health. And I'm sure this is what brings many of you here, because Carol Yarbrough is the rock star on this topic. She's a healthcare compliance and reimbursement specialist, providing a unique background in legal, technology, revenue management, clinic management, federal and state regulations. For the past 6 years, she's actively contributed to the telehealth initiatives at UC Health, and I would say nationally everywhere. She's helped everyone. She's worked hands-on with professional fee and hospital-based fee professionals to implement billing strategies, and provides real-time feedback to clinicians regarding documentation and staff with encounter guidance. Who doesn't want to know Carol? She's just an expert in all of these great things. She trains CPT coding professionals at UC Medical Center to maximize their EMR workflow. And if you want to know anything about reimbursement and coding, she is the person that you want to know. And I also have to mention that she is also not just about STEM and those STEM skills it takes to do this, but she's a steamer. She is an artist. She plays the French horn. She participates in chamber music. So she's got that whole balance, the whole right brain, left brain thing.
I'm just the general dog's body of the healthcare world.
You are, and we're so happy to have you here. Thank you so much. This is number 9. You've done 8. This is number 9, and you are the gift that keeps giving. We're so lucky to have you on our team. Thank you.
I'm ever so grateful always to come and speak to the folks that join the Southwest Telehealth Resource Center webinars. Everyone's super kind and asks great questions, and even when you stump the presenter, that's done kindly too. Even I will take correction and minimal criticism graciously. Anyway, let's get to it. These are my opinions. They're not the Southwest TRC's opinions. Many of this stuff is, of course, based in regulatory, it's come from somewhere. I don't make this stuff up. I'm sure the stuff I make up might make more sense than what we encounter in the fee schedule or what's being proposed. But there are people like us and Chris and Janet to be around and help you wade through it and read the legislative tea leaves, I guess. So These are really general objectives, just updates in the Medicare physician fee schedule with regard to telehealth billing guidance. We're still in the public health emergency phase of our lives, the days of our lives. Of course, the pandemic is still affecting many people who are experiencing illness and death still. So we're still so pleased that the PHE gets renewed and that people can continue to, shelter safely if they need to, if they're immunocompromised. So just, grateful for that, for all of our patients and Medicare, Medicaid, commercial payer beneficiaries. I'm going to try to speak to what's new for rural health clinics. As you all know, I'm a fee-for-service kind of gal, but every webinar I research for y'all to give it that Southwestern twang is a learning experience for me. And, quite frankly, a lot of the questions that are a challenge do come from FQHCs and RHCs. So the more you ask, the more we know, and we can all help each other. And then what's even more fascinating to me as an E&M coder, CPT biller coder person, is that the inpatient E&M guidelines have been updated for the year 2023. Say no more, but let's just say we all feel a special gladness that the review of systems will no longer guide what level of effort goes into an evaluation and management when people are assessing a new patient in an inpatient situation. So does that not sound intriguing enough? Now you're all like, what's happening? What's going on? If you haven't read them yet, it's going to be so exciting. Okay. So here's my section marker. I just thought this was funny. It's not certainly the status of what we know as a group here in the Southwest Telehealth Resource Center, but someone shared this slide deck with me from a law firm that covered the entire 2023 Medicare physician fee schedule. And it's like, what is the current status of telehealth? Here's what we know so far. And when I look at this, I think of probably cross state line licensure. I don't know, maybe it's not funny, but it just kind of resonated with me because I felt smarter than that slide, I guess. Okay. So I can talk about the guide or the physician fee schedule updates, but I'm not going to get to that really, because when do I ever keep to my own agenda? Okay. So I want to talk about what's going on with the PHE, because it's all going to meld into what is actually contained in the 2023 physician fee schedule. The fee schedule seems to have, well, not seems, it is memorialized, it is documented what has already been put forth by the Consolidated Appropriations Act of 2022. So say no more. So during the PHE, this is where we are now. Inpatient telehealth, if you're not at the hospital, it's what it is. It's a 95 modifier, goes on the E&M code. It's placed in service 02, which is telehealth. And if you're on campus, like, on the same block, in the same building, if you imagine Tucson Medical Center, if you're in the cafeteria and you get called and you can't go into that inpatient area because the patient is under, COVID precautions, you're on campus. And that's why you can't go see the patient. Okay, you're not going to take the call in the cafeteria. You're going to step out into one of those beautifully sunny walkways. And it's going to be place of service 21. We know this. Home telehealth, sure. So some payers are requesting a 95 modifier. Primarily, they want to know where the service is being taken place, but they also want you to bill it as if the patient had come into a clinic. So place of service 11, 95 modifier to indicate it was by telehealth. But what it means for fee-for-service clinics, non-facilities, I shouldn't repeat this so much, but I'm going to go there. I'll be quick. Is that you're going to get the full payment as if the patient had come in. You're not going to get the facility payment like you usually would in the before days, and like what you're going to get on day 152. Virtual supervision, we love it. It's an FR modifier to indicate that you're attending was supervising a resident if you're in a teaching, academic, medical center situation. You don't have to be in the same suite, the same room, the same anywhere. You can virtually supervise your resident. Audio only is allowed. Here are the codes. Certain Medicaids around the country are requesting, like Medi-Cal, because I'm so California centric. They didn't implement these codes right away. They've implemented them for calendar year, I believe 2023. I haven't seen them come up in the fee schedule quite yet. They are approved by the governor's budget. So this is where we are. So for 151 days after the PhD ends, this is what the CAA did for us and what has been memorialized in the Medicare physician fee schedule, the draft at least. Everything's the same for 151 days. Day 152, there's no inpatient telehealth because of the HRSA, address finder thing that tells you whether or not your patient or your facility is in a non municipality area. So back to what we did before, unless things change legislatively, back to putting a GY modifier on any kind of telehealth you do for inpatient. If you're in a city, you're going to tell Medicare that you did the service, but it's statutorily excluded and we're not expecting payment. And here's a place of service 02. No home telehealth, same thing. You don't get it, nothing. Maybe you'd put a place of service 10 on that. Haven't quite sussed that out yet. I'll get to that in the next slide. Virtual supervision, they're looking for comments. So I'm going to make a big pitch for folks to get their comment boots on and really comment to people in Washington, D.C. about how you love virtual supervision. And there's no audio only. Okay. But if you're a behavioral health person, psychiatry, psychology, counseling, so everything is the same. We know that there are psych codes that you bill as if you're in the clinic because there is that column on the telehealth list on the CMS website. It says can be provided audio only. You bill as if you're in a clinic. Maybe you document the Zoom didn't work, the Google Meet didn't work, something didn't work. Patient was shy, didn't want to come on camera. It's fine. 151 days afterwards, still the same. So day 152, we're going to start using that place of service 10, which is the home of a patient where telehealth service is being performed. Place of service 02 has been updated to state that it's a clinic where a telehealth service is being performed. So the patient's in a clinic. So I guess, day 152 for those other services, if you want to use place of service 10, that's probably more correct for your non-payment. If you're not, in a place where they're going to pay you to provide home telehealth. And if you're not a behavioral health provider, there's back and forth about the in-person requirement about if you onboard a new patient, you have to, I haven't quite figured it out. It says in-person requirement within 6 months for new patients. Now, is that like before you commence telehealth, or maybe you did a first telehealth visit and you have to have an in-person visit within 6 months? I don't know. Someone will straighten me out. I see the chat getting amped up there. And then audio only. Medicare was requiring the FQ modifier, and they decided that they're going to go along with the rest of everyone else because 93 is the number indicated in the AMA CPT book. So that is being updated to 93 for 2023, place of service 10. So that's what's going to happen. And so here are your eligible provider types. Again, I listed out as many, allied health type of people. I'm sure there's maybe a few more I've missed, like, LCSWs, of course, have been able to provide telehealth forever, nurse midwives forever. I think those are the only two I missed. But after that, these people we love to get services from at home won't be able to do that anymore. And again, pending legislation. Okay, so I know I was talking about telehealth, and that pretty much, those charts pretty much encapsulate what's going on with telehealth. Nothing earth shaking. The telehealth CPT listing still has the category 2, the category 3, what's covered during the PHE, what's going to be covered during the next year. So say to the end of December 2023. So it's no. It's what's covered during the PHE, what's covered up until the end of the year in which the PHE ends. And then we've got that full other year, which now is 2023, depending on how things go, to test out those codes. But with the place of service stuff going all haywire again, and I don't know what's going to happen with that. Legislation. Okay, so remote therapeutic monitoring. So many people didn't get the chance to really start up and use it because, well, for one, it's new. So a lot of people provided comments last year to the Federal Register about the draft rules around this. A lot of people asked for these HCPCS codes. So they gave us the HCPCS codes, which is awesome. And, probably they're going to be resequenced, or we'll get new numbers soon. But they didn't quite do what we wanted them to do. So people are writing comments. Okay, so last year, or starting this year, this calendar year, education is set up just like RPM. There's nothing different, still whatever. Respiratory 98976. That's pretty much the device code. It's a practice expense, and it's also covering the practice expense of the staff watching the stats, watching your dashboard of people on RTM. Someone didn't submit that day, you get an alert, call them up. Why didn't you do your PT submission? That's how I imagine people nagging people. Why didn't you do your thing? Okay, so 98977, musculoskeletal. Again, device code, practice expense. So if you don't give the patient whatever device that they're going to be using, software as medical device, the $25 that CMS has afforded, that's going to cover that cost for you. Okay, so this coming year, we've got cognitive behavioral therapy codes, psych, behavioral health, as the 989X6. Sounds like a new, like, Mazda model number. Anyway, it's new, it's a device code, but they don't know what to price it because they don't know what the devices are, even though I heard a lot of people did submit data around what a device might cost to perform, this type of therapy. So the contractor, Medicare administrative contractors are going to price these codes. They're going to, the code, they're going to price the code. And I do have a special friend at Noridian. She might be on the call. I didn't look, but she did tell me that usually the contractor pricing is reviewed and delivered by the medical director in charge of that service line, or maybe even all of it. I don't know if our sweet Dr. Lurvy is going to price this code by himself, but maybe it'll be someone else overlooking that. I know there's different medical directors for like genomics and lab medicine and all this different stuff. So, okay. So here's where the weirdness comes in. So that's what it is. They want contractor pricing. That's awesome. We can all start, I don't know, we can't send candy, but we can send love to our medical directors who are going to be pricing these. 98980 is going
Carol,
away.
I
Yeah,
have just 2 quick questions before you go any further. This is national, it's not Arizona specific.
true.
And then when you're referring to MD, that also includes DOs.
Yes.
Okay, thank you.
Yeah, it's anyone who can bill an evaluation and management code. I'm sorry I left them out. CMS does it all the time, and I should not be following that example, but we do love our DOs as well. Okay. All right, so the codes that are used for management and add-on for time are changed. So a lot of the commentary was about the fact that these RTM codes were supposed to be provided for the people actually doing the therapeutic monitoring. And since facilities don't have incident to, you couldn't direct a PT at a facility even under order to do that, because that means that would get billed out on the UB04. Hi, Mitch. So they did update the codes to allow for PT, OT, RT, SLP. And they also said, oh, and in order to bill for those codes, the 98975 and 76 or 77 have to be dropped first. And we also want the 16 days of data to influence whether or not you can bill this GRT M3. So that's a change. We don't like that. I'll show you why. We collectively. And then here's the GRT M4, which is the add-on code for this. We all know this is 20 minutes. All know that. It's 20 minutes plus an additional full 20 minutes. This is for MDDOs, NPPs, PAs, probably anyone who can bill an evaluation and management code. This has been changed to GRT M1. And again, they're requiring the 16 days of data to be submitted before billing this. And then I just put, this was just supposed to be 2 and 2 here because, this is the second grouping of this. So maybe I should put a 1 after these. Anyway, this is the add-on code, the full 20 minutes, same as above. Okay. So tiring. So there's that. And then for everyone who finally figured out RPM, they're saying that the management code should also be tied to the education and device codes, and that 16 days of data be submitted as well. I don't like that. I have an example. Okay, so if you're feeling inspired to act, if I have risen, I don't know how many people are doing RPM or RTM. They were trying to fix it for us. I mean, the love is there for this virtual care from the government. They're like, we know we want to do this and we know people are passionate about it. And this is what we've done to try to fix it. And we're not happy with it. I don't know. Are people happy with anything? Sometimes. I'm happier today because I get to speak to you guys. Last day to submit comments, September 6th. They uploaded the comments that were submitted as of July 28th. That was the last day they uploaded, I meant to say. There were 3,464 comments submitted. And these aren't comments like, I like it, I don't like it, you know, smiley face, thumbs down. These are full letters with examples and paragraphs of elucidative dialogue to CMS. And they are committed to reading every single letter. So the sooner you submit the letter, probably the more attention they're going to pay to it before they just fry out. And they do have to read every letter that's submitted by September 6th, but they might be a little bit fried by then. And the final rule comes out in mid-November, so they don't have that much time to digest everything. So the sooner the better. And you can search in topics to see what other folks said, because why not? Just take some great examples, make them your own. I always give credit where credit is due, like the attorneys that were earlier. Don't worry, I have a background up. I have a family member walking behind, can't see him. So this is where you can upload your comments, you know, turn it into a PDF, put it out there. I don't think you're going to get penalized or tracked down or called out. Sometimes they do make specific comments in the final rule, but usually they'll say contributors said, you know, they'll kind of round them up. I don't know if something's really, really amazing. Maybe they'll say, you know, Chris Martin wrote this letter and we found it to be the best thing. So we're going to call him out in the Federal Register and point everybody to how we're going to update the final rule based on these comments. Okay, so how to search the comments. I know it's kind of about the fee schedule, kind of not. Okay, so there was that URL here. You can click on it, take you there. So here's where you search. So I know I'm all obsessed with Limber Health because, yeah, and other webinars, he told you how I didn't quite stalk Dr. Gruner, but I met him on LinkedIn and we did have dinner together in May to talk about RTM, because what else do you have dinner about? I mean, it was special. And with a friend from Northwell, who also loves RTM commentary, because we just get together as coders and talk about things. So I put Mark's company there, Limber Health. You could even put in RTM. You could type in RPM, and it's a smart search. It's going to bring up every comment where that was mentioned. So I thought this was really smart, and I can't claim any kind of contribution. I just, you know, read the comment letter before it was submitted with my friend from Northwell, and we were like, this is amazing. What a great example. And so I'm bringing it up to you guys if you want to embrace it. You don't have to give credit to Mark, maybe, maybe you do, but or just kind of rephrase it so it's not complete plagiarism. I don't think his letter is copyrighted, so you could probably borrow from it if you like and just change a few words. But anyway, the whole thing about tying the 16 days to the management codes, this is a great example of like what happens. Like a clinician is going to work maybe after 3 days or transmitted, and you've had to call the patient twice to say, hey, you know, that didn't quite come through well. Or, hey, I noticed you only did half of the session. Did you complete it? And we had like maybe a connectivity problem. And then week 2, another 4 days was submitted. And I don't know, just imagine what could happen in that conversation for 6 minutes. Maybe week 3, we're back up to 10 minutes because we're kind of getting sore from doing the PT. I don't know what's happening. Week 4, week 8, blah, blah, blah. Week 5, partial week, because it's let's see, is it 30 days or is it a month? It's a month. It's calendar month. So you got a partial week there because it's calendar month. But he only looked at 15 days of data and it was 43 minutes, which would mean you should be able to bill the GRT M1 and GRT M2. Is that what those codes are? Oh, there it is right there. But you can't, because now they want you to submit 16 days of data and you haven't wasted the time, but you're not going to get paid for it. You've helped your patient. So that's why we don't like that as a collective RTM connectivity. We're the Borg of RTM, I guess. Here's another comment on virtual supervision. So you saw that whole little FR modifier is going away. So here, the Connected Health Initiative, shout out to Brian Scarpelli. I gave him a heads up. I was going to name drop him because he's one of the cool kids in the virtual space continuum. Example of another supervision, another submission. We love it. There's nothing that's going to go wrong. It's not like staff are not performing complex, high-risk surgical, interventional, or endoscopic procedures. Like you're not gonna remotely supervise someone doing a colonoscopy. You're not going to remotely supervise a resident doing an entry cut for something. I don't know. Something endoscopic, something through the abdomen. The supervision is generally probably going to be for things like simple sutures in the ED. Like, who hasn't gotten a suture in the ED? The attending does have to be there for the entire procedure if it's a minor procedure. Put them on the camera, put them on the computer so they can see, oh yeah, I am supervising those stitches. Don't stitch that. That was their finger from their other hand. So, I mean, these things are not, they're not high risk. And same thing with evaluation and management. No reason why a resident could not be, okay, these are my opinions, can be virtually supervised. My opinion. Anyway, great language in this letter too that you could borrow, you could change. And then there were also changes in the MPFS regarding emergency department services. This is also published in the AMA's 2023 E&M guideline update, which we'll get to in a little bit. People were waiting for this thing, for the ED codes to be revolutionized. Like, oh, it's going to change. Well, they're not totally different. What they did was say that like a Department of Public Health RN could, like the facility person could perform triage and then the patient leaves. Well, we don't get to bill for that right now because no MD saw that person. But now you can bill that 99281 out on the UBO4 as a facility charge. I'm not going to get into the other shenanigans that I'm hoping they're going to clean up in the final rule. Talk about that later too. I can confuse myself and everyone talking about that. All right, 12:35. Time cannot be used as a key criterion. Patient could be a 99285. You do have to still document HPI, ROS, PE, MDM. I wish it would all be on MDM, But editorial revisions to the code descriptors. Did it change? I don't think so. Okay. Someone else will call me out on that. All right. Full disclosure about this RHC information. I definitely went to the NARC website, and I give a special thank you to the person where I didn't even try to change any of the documentation as it was written on the website. These are also written in the Medicare draft fee schedule. I did read them, but this person wrote it so much better. Like I said, we're all learning. Okay. So the CAA omnibus bill made necessary technical changes in the regulation. So this was the billing of G 2025. Remember, we had to bill a certain way up until July 1st of 2020, and then 2025 on July 21st or July 1st. Then you started billing G 2025 for telehealth. There's that. We still await legislative action to make all Medicare telehealth services permanent. Yeah, that's what I've been saying. I'm agreeing the whole thing. Again, for mental health visits, these can still be done via telehealth for RHCs as well. The in-person requirement is also waived for that 151 days per the CAA, but it's going to come back into play on day 152. This year, RHCs are allowed to bill chronic care management, primary condition management. So primary chronic. It went from 2 or 3 chronic conditions to 1 for the different code sets. You bill a G0511, you get $80 to do that. Rate for the CCM. This isn't about telehealth. I mean, it's remote because you're managing this patient remotely, but it's a care management code. So CMS did propose new care management codes for a chronic pain and general behavioral health integration that can be reimbursed by RHCs, yes, and FQs, but also by using the general care management code by G0511. You can bill it alone or in addition to that per diem payment you get for patient services. And I did like that I copied and pasted this from the Federal Register. Here are the codes they're saying that are going to be the new codes for this. So it's either G0511 or it's GYYY1. They're going to come up with a number or a different code combo by January 1st, or by November 15th. So people shouldn't go out and start changing their CDM yet. The CDM, it's where all the codes live. Okay. In your software. So chronic pain management treatment, I love it. Why not? And this is an add-on code. Each additional 15 minutes. So you have to meet the 30 minutes. This isn't one of those codes where it's like over half. You have to do the full 30 minutes. So there's that whole thing about documenting for 20 minutes or 30 minutes in your EMR. How are you going to do that? It's supposed to be easy. So I did love this, that NARC, I think that's how they would pronounce it, NARC, they appreciate it, but they're saying, look, you know, it's a placeholder code and it already meets the definition of an RHC encounter. So it should be billed as an RHC visit. Ergo, it should be billed at that inclusive rate instead of as an extra code that's going to pay less. So they're going to, I'm sure you can go into the Federal Register if they haven't already submitted their comment letter and type in NARC, and you can read their full letter that they submitted. This is from their website. Same thing with general behavioral health. They're statutorily authorized to be providers in the RHC setting. They're also allowed to do telehealth. The GBH11, they can build this or build that. So here's the care management definition. It's a mouthful. So it's a care management code. Again, it's like you're taking care of everything for this patient. It's not necessarily your, well, look at this. It includes assessment, follow-up monitoring, rating scales, those depression scales and the numbered things for those tests, behavioral health care planning. So maybe you're going to include like, oh, I need you to go see this person in addition to us, and revision for patients and coordinating treatment with everybody and with your physician. So it's not a small thing. So they also think this can be billed by a G0511. That's all I got. I'm rural health people on the call. You have an amazing resource in NARC, and I found them to be amazing. And I had a really hard time trying to come up with, you know, I think providing you with sources of where you can go and who you can call and who you can write letters to is going to help as a rural health clinic. Signed, fee-for-service girl. Okay. Here are the updates for E&Ms. I want to leave time for questions. It's 12:43. Let's be quick. They're deleting observation CPT codes. How many people just learned that for their CPC exam and took a test on it? They're gone, gone, gone. They're merged into the existing hospital care CPT codes. Documentation requirements may have been different for 99217 through 220 than for a 221 through 223. I want this to say 99211 and 99. What am I saying? 9921, 99231, 99233. That's fine. I messed up. This is 99231. They're an emergent. So if you go to do a consult in patients in observation care, you're billing a 99222, perhaps. Patients in observation. If they get sent home, same day, you're using these codes, 224, 226. But if they get sent home like the next day, they're using the discharge codes as if the patient had been admitted. So what this means for your billing systems is that, again, don't change it yet, but this is what's going to happen. Place of service 22 is usually where observation codes lived. I don't think they lived in place of service 23, which is the ED. And when you're in observation, you're not place of service 21. So let's say patient comes into the ED, gets a 99285, gets put into observation. That code should morph into a 99223 because maybe it's the same provider. I don't think hospitalists are hanging out in a limited stay unit. or the observation area or status. And that morphs into a 223. And then if the patient gets admitted after 2 midnights, does that code get an AI modifier, even though it was done by the emergency doctor, emergency provider, the NP? I don't know. I have these questions. You should have them too, because it's going to be confusing. All right. It says editorial revisions to the code descriptors, blah, 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 blah. Code structure approved in the office visit revisions, meaning it's based on MDM and time or time. Deletion of confusing guidelines. Kind of confused. So for payers that still pay office consultation or inpatient consult codes like Medicaids, they're getting rid of 241 and 251, but they're not getting rid of 281. So yeah, so no more HPI, ROS, unneeded PE elements. So they've modeled these after how we updated the outpatient documentation and billing for outpatient ambulatory codes, 99202 through 99215. Time and MDM are the overriding elements. Here's what you can do when you're in the hospital. You can do all this stuff. You can't do something else that can be billed separately, and can't bill for travel, can't bill for teaching. Here's how the codes have changed. It says per day for the E&M of a patient. Well, we knew they were per day codes. I hope that per day doesn't screw up any kind of billing software, like with the vendors that are doing the billing for CMS, because it does say per day. Maybe it should say per day per specialty. Just thinking. And it says medically appropriate, and then it gives you the time. So it's either MDM or time that's going to, someone gets admitted. I don't know, but straightforward. You can't knock it down to a 99221 anymore if someone doesn't do a complete review of systems, right? These are the tricks and tools we use as coders. So start thinking about your inpatient documentation and what's going to meet these codes, these code descriptors, because HPI, ROS, 8 body systems, 10 systems, all that stuff is gone. You don't need it. It's not fully gone, but you know what I mean. So here are the follow-up codes, different time parameters. And then this is just, over 35 minutes. Didn't quite make that onto the page. The MDM description and the guidelines, super extensive. They've got these charts, massive charts on data, problems addressed. Take a look at them. We can do a follow-up on winnowing these down into buzzwords if we need to, but I just was having trouble thinking about it. So here's, it's the risk of complications. So altogether, so you got 3 elements, right? Number and complexity of problems, complexity of data, and then the chance of morbidity or mortality. If there's something that you do that's going to keep that person, functional. And if you don't do it, that's high risk too. If you do it, it might be high risk. So I got in notes. Got some proposed legislation you can go out and take a look at. Connect for Health wants to get rid of geo restrictions, include the home, and giving a patient a blood pressure cuff is not remuneration. It's not incentivizing them to practice with you because you get free stuff. Well, I'm going to go over to TMC because I got some free stuff. It's just so you can do that care at home. Why should the patient have to pay for it? Or whatever. Telehealth expansion and evaluation gets rid of the geo restrictions, looks for a 2-year extension of COVID waivers. Just so people like, you know, the CBO and other people have said they want to study the data. I don't know, it's just another healthcare thing. Seriously. And then this last one, it did pass the House. It's with the Senate. So it's, again, removing geo, patients could be at home. It includes all of our favorite providers, PT, OT, SLP, RTs, audiologists, and allows for audio only for all types of visits. I can imagine that being struck out. But when medically appropriate, I mean, it's not like I don't know, people are sensible. Anyway, so once that fee schedule is published, this is just a cool tool I want to share with you guys. People are always like asking me, how much do I get paid for this? What does this get paid for? What can I get for that? You can look at the payment lookup tool on the CMS website. It's kind of handy. You put in your put in the year, you want pricing, it's single, and then you can put in the Medicare administrative contractor that you are not ruled by, that oversee your claims. And there are different payments, of course, for different regions. So resources and thanks. Sarah Homan, I've never met you. I loved your article on your blog on the NARC site. Here it is. American Academy of Family Practitioners, thank you for your comments on the 2023 proposed rule. Thank you to the Federal Register people for publishing the draft MPFS, and of course to the AMA, as usual, for giving us our 2023 E&M descriptor guidelines. And with that, I'll take questions. And thank you for listening and being patient and listening to me babble.
Great babble. That was awesome. Thank you so much. And it's all alphabet soup to me. And it's amazing how you just rattle off these numbers. And why don't we start with the questions in chat? And it might be best if you just scroll to the top, because some of them are yes or no question, yes or no answers. That'd be great. It'd be a good start. Everybody else, please keep thinking of those questions.
And Carol, if you could just go back one slide. I think someone was trying to write down the link before you.
Oh, there you go.
Yeah. And then.
Oh gosh, you'll be able to get this off of the website like in a day.
Yeah, we'll have it by close of business today. So yes.
But I know they're so eager to go race out and start reading stuff now.
Yeah.
Yeah. My email I will give to you, just to you. You know, I spend a lot of time on email. Here we go.
Right, and we wouldn't ever give it away. So if you want to do that, that'd be great. And people loved your graphic. And,
oh, lovely. Thank you.
And yes, there will be the archive. And yes, the recording. I think we clarified that one. Okay. Would using POS 10 allow more data collection that CMS is looking for?
Using POS 10 is just going to be following the regulations when the PHE is over. So right now, when you are, while we're under the PHE guidelines, we're still submitting billing as we were told to in those FAQs. So unless specifically requested by a payer, we're not to use POS 10 yet. Because they still want to pay us like it's the patient that come into the clinic. And if the patient's at home, they're still paying us as if they'd come into the clinic. So just use a 95 modifier in the POS 11. Okay.
And I'm not sure about the registered dietitians. Was that question? Or is that another question?
Oh, the RDs. RDs have their own set of codes and their own regulations. The RDs do have other codes they can bill for nutrition. But really none of these RPM or RTM codes apply to RTs or RDs. They, yeah, there are education codes that CMS has approved, and then there are some kind of group education codes that are available. And if you send an email to the TRC, we'll answer that offline.
Is there some optimism that 151 days will buy time for Congress to move on a more permanent solution?
I think the 151 days is to buy us time to update our billing software. You know, I heard rumors. Okay, it's more hearsay. Someone said that they're going to update the PHE. Someone said, because they don't want it to affect midterms. Because if the choice had been to not extend again, that would have been done for July to not affect midterms. Now that midterm elections are going to happen around October 13th, which is the end date for this, rumor has it that it'll be extended again, which means you add 90 days or 60 to 90 days onto all the dates that are currently in effect, and then plus 151 days.
Wow, which is why we have you here, not just as the billing and coding and alphabet soup by numbers expert, but I loved your initial comment that you can help us read the legislative tea leaves, because that's really a lot of what the solutions for so many of these things are legislative, and we should all be actively involved. Now, I'm going to keep going until Chris stops me, because we still have more questions. CMS Category 3, according to an article that was in Foley.com, said that it would end December 31st. These services include therapy, electronic analysis of implanted neurostimulator, cognition, speech. Can you comment on the end of coverage timing and the Category 3 services?
Go with what Foley said, because they're smart. And but there are certain codes on there that are extended through the end of the PHE and then through the end of 2023.
And it'll all be there.
Yep. Yep.
With respect to psychiatry behavioral services coding, does this by attrition extend to addiction medicine services?
Yes, it does. Yeah. Yeah. So SUD is also can be done in the home, and it put my knees up on my chair. It can also, it does extend to anything to do with behavioral health, and SUD could be done in the home prior to the PHE.
Now, this is very specific, and I will do my best. Did you say that you can report 99457 or 98980 for RTM services?
457 is for RPM. 980 is for RTM, and that's going away.
Okay, that answers that.
So we are up on the hour, and we do have some questions still to go. We could continue going on for a while, but we will respect everyone's time, and we'll start to close the webinar. But the recording is available, and it should be available by the end of the day with the link to the handout with all of the active URLs. And Janet, you want to just go ahead and take it away? And we'll answer all the questions offline that haven't been asked.
All the questions.
All of them.
And yes, there were more, at least 9 more. So Carol, you want to hit it on my cue on my slides there? So thank you so much for joining us. Thank you so much, Carol, for your sharing your expertise. Please visit our website for upcoming webinars and events. There's the URL, as well as the archive for this gig. Next slide. Your opinion is very valuable. So we want to know what you want to know. What can we do that will be a valuable service to you? Please do the Survey Monkey. That really does help us put together the agenda for future webinars. And we would like to once again thank HRSA for helping fund this, because that, along with the Office for the Advancement of Telehealth and the Arizona Department of Health Services, is really allowing us to provide this valuable service to you and share resources and share Carol, broadcast Carol, which is awesome.
You guys. Anyway, just thanks so much for being here, and thanks for giving me a platform to spout off on. I love talking about coding. What can I say?
Well, we love to hear it. Thanks.
Thank you very much. We
Bye,
appreciate you, and we appreciate everyone who joined in today. Thanks.
Take care.